2-3 women are there who are really in the members in the community group. Main important is landowner is there, and also union Parishad member is there. It is a quite big and very important group in the community who really takes care of the community clinic, who really ensures the services, who really ensures whether healthcare providers are there, whether the service providers who are close by, and there is a system by community group, so it is less expenditure compared to other facilities. And the service providers, I will come to the point, who are the service providers. They are very known to the women of those areas, known to that special business woman, known to that shashuri. So they are really accessible. Extended with one room, and government themselves, that they are providing the service, is using one room. Plan and its partners have constructed 2-3 rooms, where also they have postnatal rooms. So it varies area to area, but they have some facility added with the existing community clinic facilities. And Plan's experience is mostly in all the community clinic. Plan has got about 8 service delivery points, where at least we have to have 4 health service providers who will provide the delivery. So we have 2 rooms for them, so that they can stay at night and provide the services. Good afternoon. As you mentioned, my name is Karen Wadman, and I am part of the Partners for World Health team that has come. And I thank you for allowing me to speak today. Myself and another member of the team, Ian Carroll, are neonatal nurse practitioners back in the United States, and we work in a pretty large unit taking care of babies, and have lots of fancy equipment and medications and ventilators and high-tech isolates to take care of our children. But what I'm here today to tell you is that you have all of the necessary equipment to get infants started on a good life. I don't have fancy PowerPoints and charts and things like that. What I have to tell you is really quite simple, and I'm probably going to be able to stick very nicely to my 10 minutes. As referred to earlier in the lectures we've had so far today, helping babies breathe was referenced, and the golden minute. Those are really the things that are of vital importance to help babies get started. A minute doesn't seem like a very long time when you're trying to condense a lot of information into a short period of time. However, if you try to hold your breath for a minute, it would be indeed a very long time, unless you're a good swimmer or have really good lung capacity. So it's in this minute that really good intervention is needed. We all know that you have the basic supplies to intervene. These things that are needed are basically clean, dry blankets or towels or material of any sort. You need the ability to be able to suction something out of the baby's airway. Certainly your clinics and healthcare facilities have bulk syringes, but if you are having babies delivered in rural areas or outside of the hospital or clinic environment, you can take a finger and swipe things out of the mouth to get that airway open for the babies to breathe. You need something to tie off the cord, hopefully something clean, a tie, a cord, a thread, a piece of towel that you can just rip off pieces and cut off the cord, and then something to cut that cord. You don't necessarily need a stethoscope to listen to a heart rate. You can just feel at the base of the cord and see if the heart rate, if there is a heart rate there. And basically what you need are skills that all of us have. You need your eyes, your ears, and the touch
to be able to really look at that baby when it's delivered and see, is it breathing? Is it moving? What's the color? Is the chest moving at all? Is there any response? And that will determine what kind of intervention you have. You know, if the baby comes out and is done for a few minutes and you dry the baby off and it comes around and starts breathing and crying, then all you need to do is transfer that baby to the mother and things are good. But if the baby is not breathing, then certainly there are things that you can do to intervene. And it's really not much. It's just stimulating that baby, clearing that airway, and watching to see if the baby does indeed breathe. We were privileged to see a few of your healthcare facilities and talk to some student nurses and practicing nurses. And one nurse mentioned to me that they didn't have a mask and a bag to use to ventilate babies, that all they did was take a piece of gauze and put it over the baby's mouth and breathe for the baby. And if that's what you have, then that's what you need to use in order to get that baby breathing. So certainly there are some babies who will not respond well to that, and you know, we all know that sometimes there are poor outcomes, but you'll be able to have a big impact on infant mortality rates by just implementing those things that the Helping Babies Breathe information discusses. We did notice that there were, in two of the facilities, the Helping Babies Breathe poster get sort of complacent about having to intervene, and then when suddenly you have a baby who's delivered and is in distress, everyone panics. And that's the thing that you don't want to have happen, is you want people to stay focused and calm and really look and assess that baby and see what's happening. So the other things that we thought about is people that mentioned that there are only a small portion of babies that are delivered in the hospital setting. Babies that are born in the home or in the rural community setting don't have access to that information. They're delivered by birth community worker birth attendants. Are those people trained or at all in Helping Babies Breathe? If that piece was put into place, that would also have an enormous impact on your outcomes. So those are a few things to think about. Again, it doesn't take a lot to really make a difference. Ideally, you would like to have two people in attendance who are skilled in resuscitating an infant, but at least if you have one, that is better than having no intervention at all. So basically, as I said earlier, you have the skills and the ability to make things be different and make your outcomes improve without a lot of excess equipment. It's just the basic information. Looking, assessing, and interacting in that first minute of time will really make a difference in your outcomes. Thank you very much.
Thank you very much. This was a pretty difficult task for me because I am probably comfortable presenting maternal health, newborn health, etc. This is a new area for me to work in Bangladesh, and not much I could get from the past experience. So my presentation, I divided the presentation in three areas. I wanted to show how the role of nurses and the relationship of that towards universal health coverage, because that's the title says that. And then the context of the nursing sector in Bangladesh, and of course, what are the scopes we have. What is nursing? I mean, it's old. This is one of the oldest of the professions, but still, I just wanted to highlight a little bit that it's the nursing care itself. It's a care for individuals, for all ages, families, groups, communities, sick or well, and in all settings. Nursing includes promotion of health, prevention of illness, and care for ill, disabled, and dying population. And also they have a role for advocacy, promotion of safe environment research, participation in shaping the health policy and in patients and in health system management and education. This is a global definition that comes from ICN, International Council for Nurses, showing the role. And how does it link to the universal health coverage? Universal health coverage is a very huge issue. One of the key essentials of universal health coverage is skilled manpower. And nursing is one of the elements in that one of the key essentials, and one of the elements of one of the essentials is nursing. So only working with nursing probably will feel only a part of the universal health coverage. But how it is linked, the way it's linked in the global discussion that with the changing trend in disease, aging population, nursing care is going to be, the need for nursing care is going to be increased in future. The role is going to be extended in terms of nurse practitioners if we look at the global scenario, and also legitimizing their role to do beyond their traditional roles, because that's needed. This is how the nurses will be able to contribute to the universal health coverage, or contributing in the countries where the nursing sector is really strengthened. Right now, approximately 30,000 registered nurse midwives are there in the market, only 70,000 in the public sector. Rest are probably some are outside of the country or some in the private sector. And in the public sector, the nurses goes up to the level of sub-district, which is Upazila. Below that, there is no nursing services available right now. In our country, the nurses and nurse midwives, the title is actually nurse midwives. We do have a separate cadre of midwives right now who are being trained, but the current ones are nurse midwives. The person who is a nurse is a midwife by default of the training. This is making a lot of contribution in the decision-making process. They're in education, training, capacity, unfavorable policy and regulation climate for managing the nursing services, the recruitment, etc. Underlying gender roles of the nurses and the perceived low esteem socially. And lack of nursing professional or leadership. These jobs of senior nursing professional also impacts the nursing education very much. And very limited capacity of implementing the operation plan, since the country runs on a sector-wide approach of HP and SDP project operation plans. There is very limited capacity for nursing sector even to implement that operation plan in 5 years' time. Now, going back to education, this is just a snapshot of the education in nursing sector, because if the education remains, compromised quality, then we don't get a good nurse for services and also for leadership. Education, there are instructors, grossly limited numbers of instructors to run the institute, to run the current institute in the country. And on the other hand, we are increasing the cadre of students without increasing the numbers of instructors, and also without giving them any training. So it's more acute. The problem has become more acute in the past. Public sector nursing institutes, private sectors, there are few good private sector institutes, but public sector institutes are really has a huge limitation even in having classrooms, books, equipment, very limited there. Courses are still rote learning type. There is no critical thinking sort of things, and investment has not happened in the recent past to improve the institutes even. In one of the one of the rooms, maybe there are 15 students staying there. So if that's the condition, the quality of education does not become very good. But what is the scope? We have to do something. This sector has not gotten much importance in the past, as I said, but there are some hope. There is a clear political support. That's what, at least it has been evident from some of the discussion that, okay, government would support, ministry would support how to improve the quality and quantity of nurses and midwives in the country. The operation plan is an excellent area. The situation has been explained nicely in the operation plan, and activities are laid out, but who does that? That's the problem. There are investments from the full fund, as I said, Canadian government, WHO, and Korean government. The vital is to speed up the recruitment of the nurses because the gaps are very much. Appointing a director, a full-time proper director should be the first step to improve the capacity. Streamlining the general recruitment and promotion rules of nurses. Speeding up the process by dealing with a clear set. Government is working towards that. There is a strategic plan and how to implement that is a question. Now, education, strengthening training colleges and institutes, increasing capacity of nursing council, which is the regulatory body to regulate the education, particularly for the public sector. They have some say on the private sector institutes, but on the public sector institute, BLC does not actually have a role to play. The way forward, the the operation plan actually lists lots of the activities what I discussed, but the capacity to implement that for DNS is very, very limited. But some technical assistance are available through a funded project. This project is going to assist the Nursing Directorate and Minister of Health and DNC to improve the infrastructure of the nursing institute, quality of education, and also developing a personal management information system for human resource management, which is absolute lacking. I mean, nurse director probably doesn't know how many nurses are working where and how they're doing.
Not get 10 minutes, and I will not take 10 minutes, and she will not be able to show me the yellow card. He will show me the red card. This is, everybody knows, and I have just shown a picture of Bangladesh. The geographical difference is 1,600 kilometers, and the event difference is 360 years. What is the similarity? Both are graphs. The graph of mother who died of PPH, postpartum hemorrhage. And the young man is Mukhtar Hossain. He is the brother of Razia Begum. Her wife is working on misoprostol, and they have saved number of lives. I will go first. Everybody knows PPH is the number 1 cause of maternal death, and with the financial support from USAID and Gender Health Bangladesh, with the government ownership and leadership is working on active management of third stage of labor and use of misoprostol to prevent PPH. The PPH was first discussed in 2006, and government has kind enough to form a national PPH task force headed by Director General of Health Services and Director General of Family Planning, and Gender Health has been assigned as the Secretariat, and Obstetrical and Gynecological Society of Bangladesh is giving all the technical support to the PPH task force. In the advocacy, the National PPH Task Force has approved to implement 2 pilot projects on PPH, as the expert identified that the misoprostol could be an excellent tool or medicine to prevent the PPH at the household level delivery. And as a process of it, the National PPH Task Force approved and has given permission to implement the Mijo-Coastal program in 2 districts. The pilot project has been implemented in 2 districts with total government setup with technical support from the Obstetrical and Gynecological Society of Bangladesh. In the slide you have seen about 95% mother who has received the medicine has used this tablet. And in the pilot project, it has been identified that government channel is capable enough to implement this program. And these are the milestones. Just in 2006, first we have identified the Mijo-Coastal. In 2008, National PPH Task Force has been approved. At 2008 to 2010, the pilot project has been implemented. In 2011, Health, Population and Nutrition Sector Program has included Mijo-Coastal to the Operation Plan MCRH and NNCH of DG Health and DG Family Planning. And 2013, Community Clinic has enrolled Mijo-Coastal as a PPH prevention for household level development. And what we have learned, the first learn I would like to say, the government ownership and leadership is essential to implement a program properly and as well as make it sustainable. And then number 2, it is the Obstetrical and Gynecological Society of Bangladesh. That means the professional organizations, they are the driving force, and National PPH Task Force has worked hard and was involved in the total process to implement the pilot project, as well as they have identified the national scale-up of the Mijo-Coastal program. And number of stakeholders, development partners, NGOs, they are working on it. What is the next step? Next step, at present, with the government leadership and ownership, the Mijo-Coastal program for prevention of PPH is implementing in 8 districts, and within June, another 10 districts will be scaled up, and for next 6 months, another 10 districts. So government has plans to phase-wise scale up of Mijo-Coastal program, and PPH Task Force will be the driving force. They will actively involve, and development partners, NGOs, they will be involved on it. And this was my last slide. The most challenging thing is that purchase of Mijo-Coastal program by the government, as well as implementation of the program through the channel. At least I did not see any yellow card.
Thank you very much to Dr. Hanif. He has been facilitating for a good number of time. I've been tired of sitting, so I just took the opportunity of standing here, and so that I can look at the back also. Respected Madam Chair and illustrious speakers and the gathering in front of us. As we see that under the banner of universal health coverage, we have covered several very important issues. One is how to improve safe delivery and reduce neonatal mortality. Also, experience from other countries as well as taking models from Bangladesh. Also looking at the scope to reduce infant mortality, nursing services and its role and prospects, and also postpartum hemorrhage for safe delivery. So my role is to facilitate. If you have questions to the speakers, I think we are not going to go and give long time. If you just identify yourself, ask one question, we will take the questions and the respected speakers will be given opportunity just to respond.